Danny. So it's really nice to get the opportunity today to sit down and speak a little bit about the fellowship and what you did as part of the fellowship, because whilst we're working together in Marie Curie Hospice, I've heard little bits about things and you've told me some of the things that you've done. So it's really nice to get the opportunity to sit down and hear a little bit more about it. So I suppose a good starting point would be if you to introduce yourself and tell me about what your role is.
So thank you, Sarah. So my name is Amara Nwosu. I'm a senior clinical lecturer in palliative care working at Lancaster Medical School. So palliative care is a speciality that we both work in, but what we do is provide whole person support for people who are experiencing life-limiting illness. So that's just not just to the individual, but to the people around them, to the friends and family. And working as a senior clinical lecturer in Lancaster Medical School, I've got both a research role and an educational role. I also work as the research lead for Marie Curie Hospice Liverpool, so I oversee the research that takes place here in this hospice. And I work as a physician, as a clinical consultant in palliative care, working in Liverpool in the Royal Liverpool University Hospital, which is one of our big teaching hospitals.
So how did you come about to applying for the Churchill Fellowship then? Sort of what made you think about that?
So some things I've always been interested in is how we can learn from other people's experiences to try to provide the best possible care for people and also to be the best possible versions of ourselves. So I'm a researcher, I'm interested in new ideas, and specifically I'm interested in technology and how we can use technology to improve palliative care. And I also like travel, and well, I did a PhD in 2015, completed in 2015. And as part of my PhD, I was able to spend a short amount of time in the USA, in Boston, Massachusetts, working with a team in the Dana-Farber Cancer Institute. And that was a really eye-opening experience for me to see how palliative care was practiced in a different country and the things that worked well and the things which we could learn from, and also providing acknowledgement about what works well in the UK. So I think I was always interested to find out how I could combine my interest in people, my interest in travel, my interest in making improvements on a day-to-day basis. And this is where I came across the Churchill Fellowship. So there are different schemes where people can travel, but the Churchill Fellowship was particularly interesting to me because it was an opportunity for people who were British citizens to travel to different countries in the world to gain experiences that they could bring back to the UK to improve things in the UK. So I actually applied for the Churchill Fellowship 2 years before I got it and was rejected. But I was really keen to apply for the Churchill Fellowship because it would give me the opportunity to travel to more than one continent to learn about the experiences of people there in the same way that I learned from my experience going to the USA. And that's part of the reason that I was so keen to go back to the USA on this time around. So the fellowship was really a fantastic opportunity for me in the UK to travel to places of interest, to learn the skills to bring back home. And it's also provides a lot of kudos for the person because it's the living memorial for Sir Winston Churchill.
Sounds amazing. So for somebody like me who might be interested in the future, a bit of detail about like what was the interview process like?
So yeah, the way the application worked, there was 2 stages. So I did an outline of the idea that I had, which was about exploring how technology is used in palliative care and where I wanted to go. So I wanted to go to 2 continents. So I wanted to go to North America and I wanted to go to Europe, specifically to the Netherlands, to see how organizations and individuals are using technologies in day-to-day clinical practice. So the first application form was really providing an outline of who you were, the idea you had, roughly where you wanted to go, and then provided that you got through that stage, you then had to do another written application which provided a bit more detail of specifically who you wanted to meet, the reasons you wanted to meet, and at that point an outline of the costs and um, exactly how you would make this fellowship work in practice. And then I went for the interview, which was in 2020, in the January, I think, and I had a panel of people who were very, very nice, and that was my memory of the questions that they asked me were really about me, asking about why I wanted to do the fellowship, how it was going to help me, how it was going to help the people around me, and how it was going to be helpful to the country. So I remember the interview being very nice and everybody being very supportive then in the interview. And one of the things which was notable about my fellowship was that the Palliative Care Fellowships were supported by Marie Curie, which was a huge honour at the time to be shortlisted, because there was representation of Marie Curie as part of that process. So it was a real kind of badge of honour that, Marie Curie, as the big palliative care charity in the UK, was supporting the opportunity for people to go working out how to improve palliative care in the country, and that's that added kind of sense of achievement because of my associations with Marie Curie as well. But the interview was a supportive process, which was really trying to understand the reasons that I wanted to do the fellowship and what I was going to get.
So before I go on to ask you about what you wanted to study and why, and give a bit more detail about that, you mentioned there that you went to the interview in January 2020, and obviously February 2020 we started to see changes in terms of COVID and the pandemic. Was there any impact on that and the places that you were planning to travel into, to the Netherlands and to the USA?
Yeah, so normally what would happen with the Churchill Fellowship is that you would, if you were appointed, you would then be told you could travel and you would have 12 months to complete your travels. You can, from memory, I think you could travel for, I think, up to 8 weeks, I think. I originally was planned to travel for 6 weeks, so 3 weeks in the Netherlands and 3 weeks in the USA. But the issue that I had was that I remember getting my letter saying that I had a place, which I was delighted about, in February. And then a few weeks later, we had the first nationwide lockdown because of the global COVID-19 pandemic. So the normal practice for the fellowships, with the expectation that fellows would travel and complete the travels within 12 months, was not possible. And we saw an amount of disruption for the next few years with the global pandemic existing as declared by the World Health Organization up until 2023. So I had a 3-year delay before I commenced my travels, which had some positives and negatives. So, to start off the negatives, I wasn't able to travel. There was lots of uncertainty, there was lots of concern about the pandemic in general. And then naturally, some of the contacts that I had in both the Netherlands and the USA were changed because people moved on to different roles. And then also just the momentum of applying, getting the interview, getting appointed as a fellow, and then not being able to travel was quite difficult, because you're on a trajectory and you think you're going to continue, and then all of a sudden things have to stop. So those are some of the negatives. Some of the positives of it was that my specific topic, which we'll talk about, I'm sure, in greater detail, was about the role of technology in healthcare, specifically the palliative care, And I think what we saw during the COVID-19 pandemic was there was a huge increase in the use of technology throughout the healthcare system, specifically palliative care, in the way that we use technology to do things like communication, to deliver patient care, for education, for resource management, for staff management, for conferences. We saw a huge amount of technologies being used at scale, at pace, in a way that we hadn't seen before. So what was really eye-opening to me was that before the fellowship, before the COVID, for me, I really had to explain to people why it was important that the role of technologies and palliative care was studied. But by the time I was able to travel, I didn't have to do that anymore, because there was a huge understanding of the importance of the role of new technologies, specifically topics like artificial intelligence, which are very much in the mainstream, never mind just in the world of science and healthcare. I think people in society are aware or have some idea of what artificial intelligence is as a subject, even though it covers many different things. And I think many people will say, well, it is important to be studied. I think the other thing that was useful is that with the institutions that I went, I was able to ask that question about how COVID had affected them, how they'd use technologies, and there were also opportunities and programs around the use of technologies in palliative care that now existed by the time I was able to travel, that didn't um, exist before. I think another point as well is that I am a dad with 3 young children. So because I had a 3-year delay to the COVID pandemic, it meant that they were 3 years older. So we all went together as a family for the majority of my Churchill Fellowship, which was much easier because they were that bit older as well. So from a personal point of view, being able to travel with my wife and 3 boys was a huge privilege and benefit, which was made easier by the delay to the fellowship starting.
Yeah, and that sounds amazing. I love seeing all the pictures of the kids and some of the places that you've got. So let's get on to the topic and what you wanted to study and why. So you've mentioned technologies, but just focus in a little bit more on that and tell us a bit more about it.
Yeah, so the role of technology in healthcare is important and it's increasing. There have been a number of reports that have looked at position statements of how we can use technology, and the consensus with things like the Topol report is that as our population is becoming older, as care is becoming more complex, as we are experiencing an increased amount of data in our healthcare service with things like medical records going to electronic mediums, diagnostic going to digital mediums. It's important that we leverage the use of technologies in a way that can be meaningful, but also improve the efficacy and the efficiency of how we deliver care and practice. Now, we're seeing many of these technologies being used for different purposes in the NHS, and electronic healthcare records is a really good example of them. However, many of the ways that technologies are used are to try to improve diagnosis, which is great, trying to improve self-management, which is also good, trying to help with communication, which is again really important, and particularly with an older population, trying to help an elderly population remain as independent for as long as possible, which is great. From a palliative care perspective, the group of patients that we have specific needs. We're dealing with people who are frail, people who have got life-limiting conditions, people whose conditions are expected to deteriorate quite rapidly. So because of that, our group of patients have got specific needs, but many people will experience the palliative trajectory of their illness, no matter how well they've been leading up to that. So before COVID, there were a number of studies which, looking at the effect of population ageing in the UK, predicted that there's going to be a 40% increase of palliative care need by the year 2040 in the UK. And when you look wider across the rest of the world, like the EU, you can see similar needs, particularly with conditions such as frailty and people living by themselves, with an aging population, with a smaller population of younger people. Because of the impact of COVID, we've seen an acceleration of the need of people with multimorbidity, many people having experienced palliative care needs now, and a huge burden of unmet need. And the challenges that all healthcare systems, particularly in the West, are having to face is how do you provide support for people who are getting older when your capacity to provide more staff is hampered at the moment. So a way that we can do that is by leveraging opportunities for digital technologies. So that's why it's important to study, to work out how technology can be used in many different ways, either to help with diagnostics, to help people access information, to help provide care for people in remote settings, for example. But this needs to be studied. I think what happened in COVID was that many of these technologies were used quite rapidly from a quality improvement perspective, which is great. However, what we need to do is to look at how these technologies work in practice and do the research from them. A big area of technologies that interests me is the application of artificial intelligence. So this is the ability of a machine to think and act like a human being. And I think we're seeing a huge increase of artificial intelligence research that's happening in general. And this is increasingly being incorporated into healthcare. However, what's missing at the moment is that careful evaluation about how artificial intelligence is used specifically to support people who have got life-limiting conditions who aren't going to improve. And there can be different ways that this can be looked at, which is the reason I wanted to go to places which are already using these technologies to see how they're working in practice, to see how the UK can learn from them.
Yeah.
Because when you're looking for examples of how AI is used in palliative care, there are maybe a few examples of how this is currently being used in the UK, but there are certain places in the world, particularly in the Netherlands, in Rotterdam, and where I was, but in the USA, across many different places, but areas of excellence are the Boston area, which is why I chose there. So, in a nutshell, new technologies are here. They've got a role in healthcare. COVID caused an acceleration of the adoption of them, but what we don't know is how we can best use them in palliative care, which is what I wanted to study.
And so you mentioned the places that you went in terms of the areas of Boston and in the Netherlands. Where exactly did you go in those places?
So in the Netherlands, I went to initially I went to Amsterdam, and part of the reason I went to Amsterdam wasn't to visit any individuals or organisations. I was very keen to look at the Nemo Museum, and this is because in order to look at technology, I was interested on looking at different aspects. So firstly, I wanted to look at design aspects. So I wanted to find places where I could speak to designers about how we design these systems well, because the evidence is that when you have a complex healthcare system, it's important that you design it well in order to achieve the outputs that you have. And I thought that was something that we are seeing happening more in healthcare in this country, but there are certain areas in the world where they have very established design programs, and the Netherlands is one of those, whereby Professor Judith Riesches, who was a contact of mine, holds a very unique design chair, which is a collaboration between uh, the Delft Technology University, which is one of the best engineering and design universities in the world, but also Erasmus Medical Centre, which is the um, largest medical centre in Europe and also combined with a university. So that was in Rotterdam. So I flew into Amsterdam knowing that I was interested to look at design and how this impacts palliative care, but how this also impacts things like engineering and computer science. And the Nemo Museum is a famous museum that is in Amsterdam, but had a very interesting exhibition on palliative care in healthcare and use of technology. So I flew into Amsterdam with my family, and we made a point of going to that museum. So I made notes, and that thought that was very interesting from like a public discourse perspective. But then specifically, we went to Rotterdam, where I went to two centres. So there was the Delft Technology of University, as I've mentioned, is called TU Delft, um, where I met designers and engineers and data scientists. And then I also went to the Erasmus Medical Centre, where I was meeting with researchers and clinicians from a healthcare perspective. And what was brilliant was Professor Judith Research, as I mentioned, is a professor in both those organisations. So I was able to meet people across those two organisations in the context of trying to link together design paradigms and also clinical and research paradigms. The other place that I visited to in the Netherlands was in Utrecht, which is called IKNIL, which is the Netherlands Cancer Comprehensive Centre. And this is a centre where they use data for the whole of the Netherlands from a cancer registry called the Netherlands Cancer Registry, where they do big data analysis. So that just means that they're using big data sets to do uh, um, analysis, which they're using artificial intelligence methods in order to look at the cancer data for the whole of the Netherlands. So they're able to provide insights about the palliative care needs that people need across the whole country. So those were the reasons that I went to those specific points to look at design, clinical research, and data analysis perspectives. So that's Netherlands. And then in the USA, I went for 2 weeks, and I chose to go to one city, and I went to Boston. And Boston is seen as a world leader in innovation. It has several world-class universities. Um, the two centres that I focused on were Harvard Medical School, which also has the Dana-Farber Cancer Institute, really as part of the Harvard University campus. And the Dana-Farber Cancer Institute is one of the leading cancer institutes in the world, where there are clinicians and researchers looking at research to improve clinical practice, and they have a palliative care division. But specifically, they have an assistant professor called Dr. Charlotte Lindvall, and Charlotte leads the Lindvall group, which looks at an artificial intelligence technique called natural language processing, which focuses on the ability of a machine to understand written text. So because of that, it can understand the free text analysis that doctors and nurses and other healthcare professionals put into electronic healthcare records systems, meaning that you're able to do really interesting forms of research, specifically about palliative care, that you couldn't do before. So I went to Boston to spend time with Charlotte Lindvall's group, but then also spent time with the teams in MIT, so the big engineering university in the USA. MIT and Harvard often flip between each other as the first and second best universities in the world, so having them both together in the same city was really incredible for me. So at MIT, I met engineers and data scientists to learn about how they use things like robotics and artificial intelligence in a healthcare setting, and we really use that to speculate future scenarios of how these technologies could be used for palliative care.
So it sounds like you met some really interesting people along the way, like from a variety of different sort of professions, different backgrounds. So you mentioned some of the things that you learnt about, and I suppose what would you summarise as the things that you found whilst you were there?
So broadly speaking, I can summarise it into 4 different areas. So firstly, I found that design was really important in any complex system, and healthcare is a complex system, but as a doctor, and I know you're a nurse, I don't feel that we're really kind of taught the importance of how a system is designed. Because I think being able to travel and seeing the different opportunities and the struggles of staff in different contexts, I realised that we were living the same experience. We all had a vision of how we wanted things to be, but often the difficulty of achieving what we wanted was the system that we were in. So, for example, we may have somebody that's having a heart attack, for example, and we all want people to have that treatment. We all want them to be able to have the treatment that the person needs. But the difficulty is sometimes the system that you're in, and your experience of the outcomes of somebody having a heart attack might be different compared if you're right by the cardiac centre or if you're somewhere rural. You know, you could have a doctor that's just as competent or a nurse that's just as competent working in each of those different areas, but it's the system that you're in will be how which will affect the outcome. And when you're talking about the role of technology in general, specific to things like artificial intelligence, and how we use other forms of data technologies, working with designers so that you can design the system and understand how the patient perspectives and the staff perspectives, particularly if there's going to be a human element that interfaces and how you get from A to B, is just really important. So I remember speaking to Zhuan Zheng, who is who completed a PhD, and she's a researcher, and she looked at design in digital health, and she highlighted the importance that trying to affect change with a digital intervention isn't going to work unless you understand what the needs of the user are, and you look at the different people that person has to pass through in order for you to achieve your outcome. So, for example, if somebody designs like a new app to do something, or a new clinical interface that a doctor or nurse has got to type into, without understanding how people interface with each other and meet each other, you may end up designing something that looks great and shiny, but is ineffective in practice because it doesn't fit into the system that you want people to use it in. So, having a positive relationship and engaging with designers was something that I felt was very important, not just from a digital health perspective, but understanding the wider healthcare context. So I think design was really important. I think I also learned that from um, a new technologies and artificial intelligence perspective, there are opportunities for this to impact care on a population level, on the individual treatment level, and from a digital legacy level. And just to go through each one, on the population level, this is my experience in Utrecht, because I saw that if you have large scale data with things like a national cancer registry, for example, but any form of large data set where you have an open source record that you can do analysis on, it gives you the opportunity to understand what is happening with people's healthcare needs. So an example that they used was because they have this national cancer registry where every person in the Netherlands is registered, and it's open source, so anybody can use this information because it's all anonymized and coded in the same way, is that they can in real time understand exactly what the cancer needs are across the whole nation, and they can plot that according to the Netherlands map, so they can work out which areas have got high amounts of a certain cancer, which areas have got a low amount. And if you can put that on the map, you can also use other data like where people are living and the distance to metro, or the distance to schools, or how old people are. So you can better understand the differences of cancer across a nation, predict how this is going to change over time, and understand how this relates to the infrastructure you have. Meaning that if you're a policymaker or you're a healthcare organization and you're trying to develop services to meet the needs of people, it's much easier to do that if you have the data. And because the data is open source, it can easily be shared. And I think in the UK, sometimes people can be worried about sharing information, but in the Netherlands, and that they were able to use the resources of other countries and regions to help them interpret scans or to provide recommendations on histology reports so that they can provide better care for their own nation. So using the skills and resources because you're able to use data. And the same, because it's open source, they give the opportunity for people to learn from their data as well. So if you have a different country that's a similar size that wants to compare their performance and the differences of cancer across different groups of people, then they can easily do that by comparing to the Netherlands data, which means that more people outside your country can benefit from it. So I think understanding that artificial intelligence and new technology can be used to benefit the population. So for the UK, because we've got wide coverage of electronic healthcare record systems, there's moves to try to have overcome interoperability issues so that different systems can talk to each other. We are understanding the importance of having cancer registries. We could learn from the Dutch. We could have make it easier for different commissioners and policymakers and researchers to compare data from Glasgow to London, from Belfast to Liverpool, so that we can try to provide better care for our patients. Second, how can AI improve care on a clinical basis? So this was really insightful from spending time in Boston in the Dana-Farber Cancer Institute with Dr. Charlotte Lindvall, specifically with the natural language processing, which, as a reminder, is the ability of a machine to understand written text. So because this could be done rapidly on case notes, you could ask questions like, how many people have had an important conversation to document the goals of care, or advanced care planning as we call it in the UK, whereby you're asking people's wishes of their care in advance, so it's easier for you to achieve those. Previously, this kind of work needs to be done by hand with case notes, people flicking through them manually, whereas now you can do this kind of research in a matter of seconds with tens of thousands of case notes. So you could ask a question like, how many people are in our hospital have had these discussions? What are the palliative care needs of people coming into the hospital? By programming an algorithm to recognize, how many people got pain, using it to work out the people who are likely to be at risk of dying or becoming unwell from having treatments such as chemotherapy or surgery. Being able to identify the people who might need to be seen by palliative care can be helpful. And particularly in the USA context, that was quite useful to understand which people might need more support from financial, the people who may need to have the hospice insurance payments activated so that they could receive the palliative care when they needed it too. It was also it was also helpful to potentially identify people who could be offered an appointment with a palliative care physician. So, for example, if we were able to use the AI algorithm to scan the notes, identify people who could benefit, invite those people to have a discussion with the palliative care team, and with the voice capture technology, that this could have been recorded and automatically transcribed straight back into the electronic healthcare record, which then reduces the burden on healthcare professionals of having to write everything down. So you can see that the application of these technologies isn't to reduce the need of the clinician, it's to try to help identify people who could benefit from having palliative care input, and then reducing the workload by doing things automatically. So, so for me, what was interesting was that in the USA, they have the benefit of having a small number of companies that make the systems that are used in electronic healthcare records systems in their hospitals, and also with the differences of how ethical approval is done by mainly the institutions rather than the national kind of ethics process that we have in the UK, means that they are able to do more of this work than we are, with some of the other protections that we have were things like the UK GDPR restrictions. However, I feel that there are opportunities to learn from this experience because if we were able to leverage the use of natural language processing to analyze free text data so that we could identify people in advance who could need palliative care needs, and that we could use things like automatic transcription of data so that we could record people's wishes and preferences and making it easier for people to make notes as they're going around so that they don't have to keep on repeating their story, to make that instantly available for people who are involved in their care. I do think that those are the kind of themes and messages that we could learn from in the UK. And I think that the other thing I mentioned was digital legacy. So digital legacy is the information that exists after somebody dies, which is digital. So often people might think about things like their photos or Facebook or other forms of social media, but it can also include things like email, banking, um, kind of gambling sites, gaming sites, other forms of documentation that somebody may have, kind of videos, voice recordings, any type of digital footprint that we leave. And because our world is becoming increasingly digital, the amount of digital information that we're leaving on a daily basis is rapidly increasing. But the challenge is that after we die, how do we manage that? Um, on one level, people might get quite anxious about that and worry about privacy. But on another level, it's about how people's lives are remembered. Because if we're living in a digital age where people are more likely to have their personal possessions of great significance digitally, for example, photos and videos and music libraries, then how can people who want to access that information, who are close to that person, who want to remember their lives, access it after they've died? I remember you saying to me that it's worth people just thinking about what is on your phone, and then if something were to happen and your kind of partner, friend, or a family member was trying to get into your phone and then couldn't because they didn't know your pass key, they didn't have the right biometrics to log in, and they couldn't access information that was in your Google Photos, your Google Drive, your Apple Photos. What would that do and how would that make you feel? You can understand the context that we're dealing with. So what digital legacy is how. So I was interested in how new technologies could change the way or support the way that people's lives are remembered. And specifically in MIT, I was talking to two researchers who were explaining opportunities where generative AI, so this is the type of AI which, like ChatGPT, where you can have it ask a question, and through its ability to understand text and words, that it's able to answer back as if you were having a conversation with a human being. So now, generative AI will learn through the information that is provided for a long period of time. So what we're seeing now through things like ChatGPT is people being able to have conversations with people who are like our digital representation of a deceased person. And that was the research that they did in MIT, where they had recreated a digital avatar of Leonardo da Vinci by using reference material from the life of Leonardo da Vinci, so that you could ask questions and look in a kind of mirror and see an image of Leonardo da Vinci, where you could ask questions about his life and his work, and the digital avatar would answer in the form of Leonardo da Vinci. And the researchers at MIT explained how this is something which could be used for people to remember from a legacy perspective, and we then got talking about future scenarios where individuals could be using this to remember famous people, so people like Leonardo da Vinci, of national importance, of international importance, but also could be used for people of national and local importance. But then how do people feel about using this to remember people on a close and personal importance as well? Because if all generative AI needs is information, and people are happy to either retrospectively use information from the past, from somebody's life, like their phone records, their WhatsApp messages, their SMS short messages, any other information that can give the characteristics of about the life of a person, um, then combined with kind of face clothing technologies where you can use photos and videos of the life of a person so you can create a digital avatar, and then also voice cloning technologies, is that you could recreate somebody that's deceased and they could look and sound and speak in a way as that living person. So that's something that could be done retrospectively with somebody deciding to recreate a deceased person without their consent, a bit like we've seen with examples with um, uh, uh, Kim Kardashian's husband, who was recreated by Kanye West, but also Michael Jackson performing um, Michael Jackson and Tupac performing at the Coachella and the Billboard Music Awards as holograms.
Yeah.
This is something that could be done without consent, or it could be something that's like prospectively done with the person's consent, like at the voyage, or it could be done prospectively where people have opted into a system where they are continuing collecting information now, knowing that at some point in the future there will be an AI recreation of them when they're deceased. So, and then a way to think about this is imagine if, you know, I don't know, a 13-year-old getting the first phone today switches on a button that says that they consent for all the information that they put in that phone to be used to recreate them after they've died. So then you may be having more than 80, 70 years worth of information that's being collected from all the different inputs that that person is interfacing with. You know, what do people think about those different examples? So we talked about future possibilities, and then that led to ethics, where I was a guest speaker at a ethics symposium in Erasmus Medical Centre with the student representative group of the master's program. So there was me, and then some other um, experts from the Netherlands in data sciences and ethics, talking about some of the ethical challenges about the roles of these technologies. And I think the example that I gave with you for the last one may have opportunities but also raises ethical challenges. But it's not just digital legacy that has ethical challenges, it's that all the examples that I've given have got some ethical challenges. So I guess in summary, the learning that I had was really interesting, and you know, you can see that I learned about the importance from design, how AI can improve things on a population level, a clinical level, and a digital legacy level. And I feel that all of those areas are ways that the UK can use that knowledge in order to try to improve our research and care and healthcare in the future.
It sounds brilliant, and you've really explained well sort of both the idea and how it translates into the UK. It's really nice to hear how that happens, or how that might happen in the future. So you've done a lot during this time. You've been to a lot of places and you've seen a lot of people and you spoke about a lot of things. I suppose what did you enjoy the most? What were your top level enjoyment?
So I think I mentioned about being able to travel with my family, which was like a huge privilege because for 1 week in the Netherlands, I was with my family, and then for 2 weeks in the USA, I was with them as well. So for me, it was really amazing to go and to experience a different country from the perspective of not just being a tourist, of going there to do a project, to work, living in an area of other people from the USA and Dutch people, respectively. But I think the family thing was a huge thing. For me personally, I felt that I developed lots of connections who I'm still connected with today, which has been incredibly useful. And from a personal level, that's helped me identify the context that I will need to do work of this into the future. So, for example, in the Netherlands, I've got connections now with people across 3 different academic institutes, you know, in Delft, in Rotterdam, and in Utrecht, with including ethicists, data scientists, clinicians, psychologists, social workers who are happy to collaborate, and we both want to do work in either direction. Mm. And then in the USA, I feel that those connections that I have with people in really prestigious research institutes in the USA and in Boston and MIT has also paved way for me to really use their knowledge to do work specifically looking at applications of AI and healthcare into the future. Mm. And again, we've had discussions with people who I've connected with in the USA recently, and we've been trying to identify a future work that can come off the back of my fellowship. However, for the institutions I visited, I think it's been incredibly meaningful as well, because I have got three affiliations of Marie Curie, Lancaster University, and the Royal Liverpool University Hospital, and there's been huge interest from those organisations for my experience, and I think vice versa, because I've gone and presented the work that we're doing here to the people out in the Netherlands and the USA. Mm. I also think it's been beneficial in a national perspective as well in the UK, because I've been invited to talk in many different contexts. So I had a keynote presentation in Hospice UK, which received excellent feedback, where I explained about my fellowship. And a lot of feedback I received from people said how it really highlighted the importance of artificial intelligence, which I feel has really contributed to discussion on a national perspective. And then internationally too, I've had poster presentations at the European Association of Palliative Care Congress, and there's been discussions about developing a European task force for artificial intelligence and palliative care. And recently I attended the European Association of Palliative Care Conference in Barcelona, and I was really pleased to see that there was a lot more new technologies and artificial intelligence sessions across the whole program, which was not the case when I applied for my Churchill Fellowship in 2020. So ultimately, a huge amount of highlights, both for my family, for me, for the organisations, for the nation, and hopefully internationally.
So what's next then?
So what's next? So I am working on a few projects that have immediately spun out from the Churchill Fellowship. One of the projects that I've been delighted to be leading is called the Digital Legacy Design and Technology Network. So this is funded by the National Institute for Health Research, Northwest Coast Strategic Partnership Grant, and the aim of my grant was to try to bring different stakeholders together to do digital legacy research. So just to remind, the digital legacy is the information that exists after somebody's died. And what I was really keen to do was to look at how we understand what digital legacy is, how new technologies can contribute to the digital legacy, what some of the inequalities that might exist of people accessing the technology, and then some of the ethical scenarios. So you can see that those themes relate directly to the fellowship that I completed. So as part of that network, we've had a project with designers, which we call the Design in Residence Program, which was based in Marie Curie Liverpool, where we were working with designer for just over the past year, who has helped to understand the hospice of the future and to do scoping work to look at the key aspirations that we want to do, both in terms of systems design, product design, and use of new technologies. So the digital design and residence program with the digital legacy technology network, design technology network that we've had, has been really useful for me to build a network of individuals who can do further research. So through this partnership, we've now got designers, engineers, architects, doctors, nurses, social workers, links with museums, and links with virtual reality companies. And I'm delighted that again, another piece of work that we are working on is a study looking at how we use virtual reality, which again is another one of those new technologies which has been highlighted as important in palliative care. I have been asked to uh, co to co-write a book about technology in palliative care. So I'm leading this project with three other authors, of which you're one of them, where we spell out the importance of new technologies in palliative care. So that is with the Springer Nature Group. So we are in the final stages of preparing drafts for that project, which will be really, really good. And I think going forward, we're looking to do more important work looking at the role of artificial intelligence, specifically in this area of digital legacy. So I know, Sarah, that you are currently working on a PhD in digital legacy in from kind of patient
Yeah,
perspectives, digital legacy, and we've spoken at length about how the outcomes of the fellowship have supported that.
yeah.
So I'm really hoping that the fellowship that I've done helps to improve knowledge for people who are interested in this area, to really highlight importance for why it's a priority in the UK, and to provide a practical framework that um, uh, people can use to develop future research in this area. And from a personal point of view, I'm really enjoying the opportunities the fellowship has given me and the work that we're currently engaged with.
Well, thank you so much. It's been lovely to hear about your experiences, sort of, what you've learned while you've been there, how you got about doing the fellowship, and sort of the impact that it's had so far. Because I've sat in your talk in Hospice UK, and I saw the impact that that had on people nationally, and how it's going to be, you know, potentially going to help to change things going forward. I'm really excited. So thank you very much.
Thank you, Sarah, and thank you.